Welcome back to...
What were we talking about?
The Generalist. I don't remember. Who are you?
What are you doing here?
This is part 2 of Dementia of the CCFP 105 Topics podcast. Here we are covering objectives 4 through 10 because 1 and 3 were too big. So welcome back. Settle in. We're going to get this one done for you, and you're going to be so smart. Objective 4. In patients with dementia who exhibit worsening function, look for other diagnoses. These diagnoses may include depression, infection, concurrent medical illness, substance use, etc.
This one really wants us to go back to our differential and rule other causes of cognitive decline before assuming that the dementia is simply worsening. Get that history and physical, rule out a delirium from all those causes we talked about, and assess for substance use. You can repeat your geriatric depression scale or use the 2-question screen, which is less specific but more sensitive. This includes during the past month, have you been bothered by feeling down, depressed, or hopeless? And during the past month, have you been bothered by little interest or pleasure in doing things that you used to enjoy?
If the overall picture of their decline has been stepwise, remember to think about concomitant or continued vascular dementia and whether an intervention or workup is necessary to prevent further decline. Stepwise, vascular. Objective 5. When disclosing the diagnosis of dementia, do so compassionately, respecting the patient's right to autonomy, confidentiality, and safety.
This can be a tough subject for the patient and their family, and there may be a great deal of denial or shame around a diagnosis of dementia. And as we talked about before, the patient's insight can be quite limited, so they may not understand why you're saying that they have dementia.
You can use your spikes approach to the situation and to reassure the patient and the family that you are there to support them. Check out episode 10 on bad news for a complete rundown on this approach. Objective 6. In patients with dementia, assess competency to involve them in decision-making as appropriate to the situation.
Competency is another subject no one wants to touch, but it's extremely important, especially if you've just demonstrated that the patient's cognition is not wholly intact.
Before we talk about it, let's be clear on capacity versus competency. Capacity refers to a patient's ability to make an informed decision about an issue, while competency is a legal term referring to whether an individual has a legal right to make decisions for themselves. A competency judgment is informed by a capacity assessment.
Each jurisdiction will have their own forms and processes for assessing and documenting incompetency. The general approach for your capacity assessment is to determine if the patient has the ability to understand a situation and the options, appreciate the potential consequences of that choice,
and to provide some level of reasoning to support their decision.
Some sample questions that you might use would be, can you tell me in your own words what I just said about this?
Based on what we just discussed about this, what would you choose?
Do you think that it is possible that A can benefit or harm you?
How might this affect you? And how is A better than B?
I find those situation questions mentioned earlier super useful here, and they don't have to be medical at all. You could ask all these questions about finding expired milk in the fridge, or getting a flat tire, or having a bill to pay. The point is, does the patient have the cognitive ability to understand, express a choice, appreciate the consequences, and provide their reasoning?
Objective 7. In following patients diagnosed with dementia, assess their function and cognitive impairment on an ongoing basis, assist with and plan for appropriate interventions in the context of disease progression, manage comorbidities, including mental health problems based on the goals of care, and review the pharmacotherapy.
Most of this objective should be common sense. However, to be explicit, patients diagnosed with dementia should be seen in person at least annually. Regular visits will allow a general assessment of the patient's dementia, their other medical conditions, as well as their social situation and the caregiver's status.
As we'll talk about in Objective 9, if there's a concern for driving, these patients will need to be seen and more formally evaluated.
Often more frequently than annually.
Yeah.
As I think goes without saying, it is extremely important to have a good advanced care planning conversation with patients with dementia and their family. Ideally, this should occur early on in the disease process while the patient is able to participate fully in the discussion. This helps direct where the patient will live, when that might change, who and how they will be taken care of, etc.
Along with this is the actual goals of care designation for the patient. Neurological outcomes after cardiac arrest and similar events requiring resus or intensive care can be poor for those with intact cognitive function at baseline, but this is likely worse in those with pre-existing cognitive deficit. Patients and their families should be aware of this and gently encouraged to explore the goals of care that are appropriate to their situation and the current status.
Of course, this can and should be revisited intermittently, or if there are changes in cognition or comorbidities.
Polypharmacy and medication side effects are a problem for our elderly patients, and especially those with tenuous cognition. Consideration needs to be given to discontinuing any non-essential meds, and caution should be used when prescribing neuroleptics, for example, as patients may be prone to side effects. This is especially true for those with the frontotemporal dementia. Objective 8. Assess the needs of and supports for caregivers of patients with dementia.
Caring for patients with dementia can be challenging for clinicians, even over short office or ED visits. Now imagine a caregiver managing this patient's needs and behaviors day in and day out. This takes an unbelievable amount of energy and compassion. We need to respect this and provide as many supports as we can.
So for information though, there's a number of good online resources available to support patients, their families, and caregivers. These include Alzheimer's Society, Dementia Friends Canada, and the Alzheimer's Association. These are awesome organizations and they will be linked to in the show notes.
For more physical things, consider daily home care visits to help with medications and bathing, for example. Consider OT assessment to ensure the environment is as functional as possible.
And look into long-term care before those care requirements become too much for the family. The wait list can be long. There may also be respite options in your community, so try and find out what's available and offer that to patients' families when they might be needing it. Objective 9. Report patients with dementia to the appropriate authorities if you suspect they should not be driving.
The CMA provides the definitive guide on fitness to drive from a medical perspective in a 192-page PDF document available for free to all CMA members.
So for the rest of the episode, we're going to read through that 192-page document from start to finish, so strap in.
That's why we separated this into 2 episodes, right?
The guidelines suggest using multiple cognitive scoring tools to assess the level of impairment, which, as we mentioned before, can include the MMSE, MOCA, clock drawing, or the trail making test.
The CMA suggests that given the test results and the global impression of the patient, classify their impairment as mild, moderate, or severe.
Severe impairment is absolute contraindication to driving.
Moderate impairment presents a high risk and driving should be seriously discouraged. If a patient or family insists that they continue driving, further assessment must be completed.
Mild impairment presents some additional risk from the general population, but it's not a contraindication to driving. If there's any concern or doubt, further assessment is recommended.
Patients with mild or moderate impairment that continue to drive are at risk of deteriorating and have increasing risk with time. They should be followed closely for further cognitive decline. This means reassessment by the clinician at least every 6 to 12 months, sooner if a decline is suspected.
The CMA also suggests asking oneself, given the results of my clinical assessment, would I let a loved one get into a car that this patient is driving?
Would I want to have a loved one cross the street in front of a car that this patient is driving?
For each question, 3 answers are possible. Yes means there's no concerns that should trigger further testing. Uncertain means that more tests are needed. And absolutely not probably means that the risk is clear and the ministry should be notified.
Another super helpful document is the Driving and Dementia Toolkit from the Regional Geriatric Program of Eastern Ontario. It has an algorithm and checklist to assess severity of impairment. This is linked in the show notes and makes this process way easier.
In addition to the pieces included by the CMA, this checklist also includes the type of dementia, family concerns, physical ability, drugs and meds, a ruler drop test, and a judgment question. If any of the checklist questions are positive, this is an alert that driving might be unsafe.
I think I will definitely be using the checklist for assessing my patients in the future.
Same. For those in whom driving risk is uncertain, there are road safety tests that patients can be required to take. Don't feel bad about making the patient take one of these if you're uncertain. Yes, it costs them money and time, but also an accident would.
It is important to note that the requirement to report fitness to drive varies by province. Some provinces have mandatory reporting, others are discretionary, and BC has mandatory reporting only if the patient continues to drive after being told not to. Link in the notes.
And there's an awesome screenshot too of that checklist that you can grab. Oh, as well as a link. It's all there. It's there.
It's all there. It's there.
Objective 10. In patients with early onset dementia, consider genetic testing.
Inherited Alzheimer's typically follows an autosomal dominant pattern. 3 genes have been identified as having a strong link to early development of Alzheimer's so far. These are amyloid precursor protein, or APP, presenilin 1, and presenilin 2.
And those with trisomy 21 have an additional copy of that APP amyloid precursor protein, which makes them more likely to develop Alzheimer's before 50 years of age.
Testing can be performed for each of these 3 genes, either in young symptomatic individuals or preemptively in those with a family history.
Because of the personal and familial implications of gene testing, it's important the patient or their guardian fully understand the risks and benefits of testing and make sure that consent is documented. If they're unsure or you're not satisfied that they really understand this, refer them to a genetic counselor to have further discussion prior to testing. These folks might need referral for genetic counseling after testing anyway, so it doesn't hurt to refer early.
There is also an association between late onset Alzheimer's and the gene apolipoprotein E, epsilon 4, but testing is not recommended as the predictive value is not great and clinical use is limited.
Oh my goodness. Who thought dementia was going to turn into this?
It was so long, but it's done now.
So that's a massive thanks for all the effort that Chris put in to make such a good 2 episodes.
Thanks, Caleb.
And there are obstetrics episodes appearing in your podcast feed. It's an awesome team of 3 people with Kyla leading the charge. They're so good. You might remember her from the contraception episode that was so well done as well. So listen to those guys if you have any interest at all in low-risk obstetrics, and they're going to keep sending you episodes while we get the CCFP episodes in your brain.
Check them out.
Check them out. Anything else? The wonderful new infographics and episode art that you're seeing from one of our new wonderful med student contributors. They're just folks just like you listening to us right now that wanted to offer a hand. This is a collaborative effort across the country getting this done. So thank you guys, and thanks for reaching out. Okay, I'm actually done.
Long outro.
Bye guys.
Goodbye, everyone.